talking on injury mechanism and patient profiling who come to us with ACL injuries. So it's, as said, the injury mechanism, it could be a non-contact injury or a contact injury. So I'll just show you a few videos with which patients come to us, because nowadays videos have become very handy. They have CCTVs or the mobile recordings whenever they are playing. So this was a boxer in red jersey. So he fell down. As we know, all these athletes, they are very hardly trained, but he tried to play. He was not able to do that. He buckled his knee and he broke his ACL. So another player who is a recreational player, he tried to catch a ball. He got a hyperextension injury. Another gym lover, a fitness enthusiast, just look at his left tibia and it just breaks. So that's how it happens. So a few of the kabaddi players, we don't have footy here in India. We have kabaddi players. It's a kind of contact sport. His knee buckles again. It's almost similar kind of injury. Or improper jump landing for a basketball player. So these are very common scenarios which we get from the professional athletes or a recreational athletes. And it can be a contact type of injury where a grappler just holds the leg and just move it around. So again, this can give rise to an ACL injury. But more frequently in India, we get these kind of patients as well, who are just walking down the ramp and fall on the potholes. So why it is important to see all these videos is because, and we should know the mechanism of injury, because when we are reconstructing the ACL, we have to rectify these problems as well. So we have to tell them that your landing pattern was not right or this was wrong. So you have to work on all these problems, and this will prevent the re-injury of the reconstructed ACL. So this takes us to the patient profiling. So just not look at the knee, look at the whole patient. So we have a very microscopic vision. Being trained in an orthopedic hospital, we just look at a knee of the patient, but it is very important we should look at the patient as a whole, because we are treating a patient, it's just not the knee. So history is of prime importance, because just one single history can change your game plan in the entire management of the patient. So be very patient and talk to your patient. So take your time, spend some good time with the patient, knowing the entire history. So you should also know the type of sport he is into, the position and his role in the game, the muscle firing pattern, and if he's in season or an on-season player, and if he's preparing for some tournament, how much time is left for some major tournament, which is his probably help his career to grow, and or his future goals as an athlete. So you should know what type of sports they are playing. So, and the positioning, and supposedly middle blocker in a volleyball court, he has to block, and at the same time he has to prepare a ball for a volley for that right side hitter to come in and smash it. So you should have some idea that how they are going to do it. For a right-handed person, his left knee is at high risk of getting an injury. So, and then in season and off season, so there are sports seasons, because they can be off season, and when they injure themselves, you should know how much time is left for it. If it's happened in season, then you have to change the training pattern. As we all know, he was injured in middle of the season, and we were waiting for another Champions Trophy to happen, but he was out of Champions Trophy. So it's very important that we should know when the athlete is getting injury, and we should try to work on it. The clinical examination is one of the most important aspect when you start looking at the patient. So I will always say look at it like A, B, C. Look at the alignment first, look at the balance, stability, and then look for the cushions and the cartilage. So look at the leg from all the sides, just not from front. Look at from front, side, and back, because a different angle will give you a different information. Normally, patients come to us dressed in tight jeans, narrow-fitting jeans. So always keep a shorts in your OPD or in your office, so that you can expose the knee and have a look at the knee from all the angles. Look at the alignment. If it's a mal alignment, you have to work on it. You have to look at the landing pattern again. There can be a muscle wasting and a flexion deformity. So this is very important when you are seeing a patient with a knee injury or an ACL injury. Alignment, again, as I said, in few patients, they have a valgus alignment, which place their risk at getting a higher chances of an ACL injury. Stability testing, again, is very important. You have to relax the patient. So whenever you are doing an interior drawer test, you must be aware of it. Always look for the translation of tibia and the quality of the endpoint, and compare it to the normal side. Quality of endpoint is very important, and just don't look at translation of the tibia. There are various tests, anterior drawer test, then Lachman's test. That's how it is being done. Look at the quality of the endpoint. It is hard, firm, or soft, which will give you a clinical diagnosis, and you just need an MRI to correlate it with the clinical unstable knee. Or a pivot shift test, slightly difficult to do in OPDs when patient is anxious, but if you are experienced enough, you can although get it positive in your OPD settings as well. Sometimes you cannot elicit any of these tests, so this test comes handy when the thigh is bulky. So this is called Lely's liver test, when you have to put your fist on the calf and try to push the thigh down. If the heel doesn't come off from the bed, it's a positive for ACL deficient knee. Examination under anesthesia, again, is very important because there's enough laxity or a grade 3 pivot shift test. You have to change your plan of treating this patient, or you have to add on a procedure to it. So these grade 3 pivots can also happen when there's a meniscus ramp lesion or a lateral meniscus root tear. So always suspect these whenever you are having a grade 3 kind of pivot shift test. It's just not the ACL which is giving the stability to the knee. It's the other structures which are also providing stability to the knee. So muscle firing and the inherent stability has already been spoken about by the previous speaker. We should know whether the leg is ligament dominant or a quadricep dominant. So also the leg dominance, which leg is dominant, and the trunk dominance. So investigations, the most important investigation I would like to get is a monopedal weight-bearing X-rays, just not the weight-bearing, but a monopedal stance view, and a good quality MRI, just not 0.3 Tesla. You need to have a good 3 Tesla MRIs available very easily. And I have a performer in my OPD setting where I just write plus minus on this performer, and I can actually write my clinical impression and just correlate it with the MRI findings. So which graph to choose for which patient will be definitely touched upon by my next colleagues, but one graph doesn't fit all, so you have to choose as per the support. So BPTB has a different role, peroneus longus has a different role, quadriceps autograft has a different role. Similarly, hamstring has a different role. So you have to choose it in particular patients. So these papers come very handy when you can actually read it and find out. Just I'll take a minute more. So peroneus longus is a promising graft which has come off late, but it has to be used with a caution in patients who are having a flat foot or a high arched foot, but we are still waiting for evidence whether this is a good graft or a not good graft. And few patients who have a lot of ligamentous laxity, so they need extra procedure like lateral exarticular tenodesis or ALLR or anterolateral ligament reconstructions. Fiber tape was very commonly used or abused, so it has its own benefits and disadvantages. Again, there are few synthetic grafts which have come into the market, which can be customized as per the need of the patient. So the take-home message is always listen to your patient, be very patient and listen to your patient very nicely, and customize the procedure as per the need of the patient. Just don't choose one procedure for all the patients. Thank you.